welcome to another discussion on Pediatric Masterclass, which is approach to anemia with hepatosplenomegaly. So this again is a commonly encountered clinical scenario that we see in our day-to-day practice. And what is more important is going to be the approach. I mean, how do you approach a case that has anemia with abdominal distension? So we look at the differential diagnosis. We look at how we can rule out a few differentials on the basis of history, then come to a set of differentials, then how do you confirm those on the basis of examination, and eventually come to a limited set of differentials in your final diagnosis. So without wasting any further time, we will begin the discussion. So we're going to do it as a case presentation. So I'm going to present, you know, a case of a 1-year-old who's come with these complaints. So before we begin with the discussion, let's look at each and every set of questions that you will be asking in your history and what is the significance of each one of them. So the first thing is your demographics. Yeah. So with demographics, like any other pediatric case, you will ask questions based on age, sex, birth order, consanguinity, resident of or hailing from, belonging to what religion, and informant being whoever's informant, what is the reliability. Now, when we talk about all of these questions with respect to a case that has anemia with or without abdominal distension, there is importance and there's a lot of significance to each and every question as to why we ask it and what extra information is each of this point going to provide, which will help you come to your diagnosis. So if you look at the age, how does the age of presentation give you a clue to the diagnosis? So we all know that there's a certain age that beta thalassemia generally presents. So my question to you all is, what age does usually beta thalassemia major present and why? So you can put the answer in the chat box. This is a very basic question. This is a question that, if you have a thalassemia case, you will be asked that what is the age of presentation and why is it so? So what is the age of presentation of beta thalassemia major and why do they present typically in between that age? Okay, so the answer is beta thalassemia major usually present between 6 months to 2 years of age. Why is that so? Why is it that you never see thals presenting in the first 6 months of life? And the answer, like someone just said, is because of hemoglobin F or fetal hemoglobin. So what happens is the composition of hemoglobin in the fetal life is different. It's called HbF, which is called the fetal hemoglobin, which is made up of 2 alpha and 2 gamma chains. What happens is at birth, it starts transitioning towards adult hemoglobin. Okay, so it takes about 3 to 6 months to change from HbF to Hb, adult hemoglobin, which is predominantly Hba. Now, when you look at Hba or the adult hemoglobin, it's got 2 alpha chains and 2 beta chains. Now, we know that beta thalassemia is characterized by deficiency of the beta globin chains, right? So you don't have beta chains, as a result of which your Hba reduces, correct? So the transition from HbF to Hba is not able to happen because of deficiency of the beta globin chains, is because that's what you see in thalassemia. And deficiency of these beta globin chains is what starts manifesting as anemia. And you see clinical symptoms from about, starting with 6 months to 2 years of age. So that is the usual age of presentation of thalassemia. It's 6 months to 2 years. And this is the reason why, because you don't see the transition from HbF to Hba because of the deficiency of beta globin chain. So this is a question that there's a high probability to be asked in your exam as to what is the age of presentation and why is it so. Why is this important? So this is a hemoglobinopathy or a hemolytic anemia. When we talk about thalassemia, it's the most common hemolytic anemia in our country. And the age of presentation is 6 months to 2 years of age. We just saw that. So what are the other hemoglobinopathies or hemolytic anemias that can present at birth? Okay, we just said that HAL never presents at birth. So there must be some that, if you have severe hemolytic anemia with jaundice or even requiring blood transfusions presenting in the neonatal period, what differentials will you think of? So in that case, hemoglobinopathies that can present at birth include alpha thalassemia, severe pyruvate kinase deficiency, G6PD deficiency, and even hereditary spherocytosis. So, this is the importance of age of presentation. Depending on what age the child first presents with, symptoms suggestive of hemolysis and anemia, you can think of, a differentials. Like if you have somebody presenting at birth, beta thalassemia major is out of your differential. So that is the importance of clearly asking the age of presentation of clinical symptoms in that particular patient. Now, next, what is the importance of sex? So G6PD deficiency, hemophilias are X-linked recessive disorders, so you'll see them more in the males. So that is why it's important to ask whether the patient that you're dealing with is a female or a male child. Next, consanguinity. So autosomal recessive diseases run in the family. A lot of these hemoglobinopathies, a majority of them are autosomal recessive. So you might have a history of, affected family members in the family with similar histories. Let's say if you're talking about hemolytic anemias, you might have somebody who's also receiving blood transfusions, has a history of jaundice, has undergone abdominal surgeries like cholecystectomy, splenectomy, has had gallstones, etc., etc. That is why consanguinity is very important. It might happen that you have your child who's say beta thal major, and the parents are going to be carriers. So they might be asymptomatic and they've never presented. So probably they just don't know that they are carriers of beta thalassemia. But it's very important to ask for this history of consanguinity because it gives you a clue to whether you're dealing with an autosomal recessive disorder or not. Now, residence. Now, residence is extremely important when it comes to a case with anemia. Okay, because there are certain regional belts in the country, like if you see the ones that are shaded, that have a higher prevalence of hemoglobinopathies as compared to the other parts of the country. So if you look at this map, states like Gujarat, Punjab, Rajasthan. In the south, you have Karnataka, Tamil Nadu. On the east, you have West Bengal. All of these regions have certain belts that have a higher prevalence of beta thalassemia and other hemoglobinopathies, also like sickle cell, etc. Even within certain states, like let's consider Maharashtra, there are certain regional belts in Nagpur, Gadchiroli, etc., that have a higher prevalence of these hemoglobinopathies. So knowing the residence is very important. Now, when you are taking, a case like, say, for example, in Mumbai, probably the patient is residing in Mumbai because they've migrated from their village, but they might be hailing from one of these locations. So that is the reason why asking history of residence as to where they're living currently and where they're hailing from becomes extremely important when you're dealing with anemia because there are certain belts that have a higher prevalence of hemoglobinopathy. So they'll give you some more kind of information that you will need particularly with this case. Now, what is the importance of hilly areas? So certain hilly areas in the country, no matter what, whether it's the west, it's the south, you will see a higher prevalence of these hemoglobinopathies in certain hilly areas. Now, there's, a hypothesis that it's nature's way of protecting them. What is thought of is that we all know that malaria is more predominant in the hilly areas because, there are a lot of trees and a lot of breeding of mosquitoes. And we know that those who have hemoglobinopathies do not have severe malaria. Okay, so malaria is not seen in those who have sickle. And that is the reason why, it's nature's way of protecting them that, you already have a higher prevalence of mosquitoes, you already have a higher prevalence of probably getting malaria. So let's protect you from that by, hemoglobinopathies. And also another reason being that hilly areas, you see a lot of consanguinity, people tend to marry within the caste, within the community because they're small communities. And that's the reason why you see a higher prevalence of hemoglobinopathies in certain hilly areas as compared to the other plateau and other terrains. Okay, that's the importance of asking for residence and hailing from in this case. Again, religion. So certain religions or certain castes or certain communities in the country, again, see a lot of hemoglobinopathies run in the family. This is another question that can be asked. So you have Sindhis and Punjabis from North India, the Bhanushalis, Kachis and Lohanas from Gujarat. You have the Mahars, Kodis, Buddhist Agri community from Maharashtra, and the Gaudas and the Lingayats and GSBs from the south from Karnataka. Okay, so these are the common castes that have a higher prevalence of hemoglobinopathy. So this is something again important to ask. So having done the demographics and understanding the significance of each and every question that we've asked, let's move on to the chief complaints. So remember, there are two ways of presenting this kind of case. The first way is going to be like, it's a new case that's presented for the first time with these complaints of anemia, pallor, abdominal distension, etc., and has not been diagnosed or probably has been diagnosed, outside and has been referred to you. That is one way of how this case might present. An other way of how this case usually presents is, let's say you have a thalassemia unit in your hospital and you have patients, who come in regularly for their monthly blood transfusions. So many a times what happens is, a patient is chosen from the thalassemia ward and is kept for your exam. So probably that patient is asymptomatic and has come for regular blood transfusions, and you're taking that case. So he's already diagnosed and he's a known case of a hematological disorder requiring repeated blood transfusions. Or on the other hand, like I said, the first type, which is a new case that you will have to ask for history, examination, and then come to your diagnosis. So the second one is a lot more easier because you know what you're dealing with. So we are going to be stressing on the first type as to how do you actually approach a new case with anemia and hepatosplenomegaly. But yes, definitely in the middle, I'll also be giving you clues and snippets about what questions you will ask if you get a known thalassemic who's been kept for your exam. So, I'll try to balance between the two. If you have any questions, you're more than welcome to ask. So let's see the chief complaints. So there's a 10-year-old girl who's presenting with pallor noticed by the mother since 8 months of age, with easy fatigability noticed again since 8 months of age, abdominal distension noticed since 9 months, that is almost since 1 month back, and breathlessness for the past 1 week. Okay, so again, I'll repeat. My chief complaints are pallor since 8 months, easy fatigability since 8 months, abdominal distension since 9 months of age, and breathlessness for the past 1 week. Okay, now let's see how do we describe the history of each and every presenting complaint. So the child was apparently all right till 8 months of age, but the mother started noticing pallor and reduced activity. Now, reduced activity, how did she kind of, come to the conclusion that the child has lethargy, reduced activity? Because she was playing less as compared to her peers of her age. Okay, so that is how the mother thought that, there's some kind of reduced activity and lethargy. And she started appearing slightly whiter than she normally did. So that's pallor, reduced activity with lethargy. Second chief complaint was abdominal distension. So abdominal distension, she started noticing since 9 months of age, where incidentally she found that while giving her a bath, it was insidious in onset and it has been gradually increasing progressively. The abdominal distension is more obvious in the upper half of the abdomen as compared to the lower half, and there's no associated constipation, vomiting, fever, or pain with the abdominal distension. Okay, so that's how we describe the second chief complaint of abdominal distension. The third one was breathlessness. Now, breathlessness, again, she's noticed for the past 1 week. Again, that has been insidious in onset, has been gradually progressive. And another way of describing breathlessness typically is what grade of breathlessness do you see? So, like you have the NYHA in adults, you have the modified ROS grade in children. Okay, so you have 1, 2, 3, and 4. The grading is pretty similar, just that the way you assess it is different. So, like class 1 is asymptomatic, 2 is mild tachypnea or diaphoresis while feeding in infants. Because this is an infant, let's talk with respect to that. 3 is marked tachypnea or diaphoresis while feeding. That means there's some kind of activity or exertion that's going on. In class 4 is symptoms even at rest. Okay, so let's say she had modified ROS grade 3 of breathlessness that the mother noticed that she had marked tachypnea, diaphoresis, feeding difficulties, uh, you know, while she was breastfeeding. So that is the description of the chief complaints. So now what are we dealing with? Let's say we know that the child has pallor as per the description of the mother. Along with pallor, there's complaints of easy fatigability, lethargy. with breathlessness for the past 1 week and abdominal distension. So, with these chief complaints in mind, what do you think we're actually dealing with in this scenario? So, this moreover looks like, anemia with or without congestive cardiac failure, because that's what is causing the breathlessness, with or without abdominal distension, which most likely looks like hepatosplenomegaly. So overall, if you see this case, goes in the direction of anemia with congestive cardiac failure. So that's pretty severe, right? So severe anemia with CCF with hepatosplenomegaly. So this is what I'm thinking of with respect to an overall summary, if I have to, with the kind of chief complaints that I have received. I haven't asked any questions further, but this is what my thought process or what I'm thinking in terms of is, moving ahead with. So now if we have anemia with hepatosplenomegaly, what are the differentials of anemia with HSmegaly? Again, this is another question that can be asked in Viva, that if you think you're dealing with anemia with HSmegaly, what are your set of differentials? So it could be hemolytic anemia, which is again the commonest cause of anemia and HSmegaly in the country. Hematological malignancies like leukemias and lymphomas, infection like chronic malaria, Kala Azar, or even CMV, storage disorders like Gaucher, Niemann-Pick, and your glycogen storage disorders, and liver disease with portal hypertension. So, in terms of order of most common to, I would say, least common, this is the differential of anemia with hepatosplenomegaly. So now, we're still not sure as to whether we're dealing with anemia or is it just anemia with hepatosplenomegaly. We need to ask furthermore set of questions to be sure as to what exactly are we dealing with, and that is where your negative history comes into picture. So it's very important to remember that whenever you're taking negative history, you should know the set of differentials that you think you might have in this case, and your questions in your negative history have to be pertinent to that set of differentials. So, like if you didn't know causes of anemia with HSmegaly, you will start fumbling with your questions in negative history. So that's the reason why I have put these set of differentials that okay, probably this is what we're thinking of, and let's ask questions to be able to rule out, say, which of this is not likely in this case. So when you talk about negative history, first is because we have breathlessness, and that is a pressing issue right now. We need to know what the causes of breathlessness are. So one of the other common cause of breathlessness could be a cardiac or a respiratory cause. So for cardiac cause, I've asked for history of decreased urine output, facial puffiness, or difficulty feeding. Now, difficulty feeding is something that can happen even in CCF, not because of cardiac cause. So, like in this case, the child was having feeding difficulty, but oliguria, facial puffiness, and the presence of these complaints not for the past 1 week, probably even longer, that the child has chronically had these complaints of poor feeding, etc., points towards a more long-standing cause that could be cardiac origin. Okay, so there is no history of decreased urine output, facial puffiness, or feeding difficulty. Now, what other questions will I be asking to rule out the differentials that we just saw in the previous slide? So in hemoglobinopathies or in hemolytic anemias, the most common one is beta thalassemia major. Others, you can have sickle cell anemia, you can have hereditary spherocytosis, and enzymopathies like G6PD deficiency, pyruvate kinase deficiency, etc. So let's see whether we're able to look at which exactly hemolytic anemia we're dealing with. So there's whether there's history. The next question that you will ask is whether there's history of pain, abdomen, limbs, chest, headache, or convulsions. This is to rule out sickle cell vaso-occlusive crisis, which is another type or another common type of hemoglobinopathies that we see for after beta thalassemia major, obviously. Then for an infective etiology, whether it's chronic malaria, Kala Azar, etc., whether there's history of high-grade fever with chills, which we don't have, history of bone pain, weight loss for malignancies like leukemias and lymphomas, whether there's history of recurrent infection or bleeding from the other sites or any skin rash, petechiae, purpura. Now, this is important because you want to look at whether it's only anemia because the mother is complaining of pallor. Is it only affecting the RBC cell lines, or is it also affecting the other cell lines? So is it going more towards pancytopenia, or is it, favoring anemia? So if you have pancytopenia where all the three cell lines are going to be affected, you will have anemia with thrombocytopenia and leukopenia. So there's a risk of increased infections, that you could have bleeding from the other sides. So when you have all of these, it points more towards, some problem with the bone marrow and the maturation. So whether it's only anemia or whether it's affecting the other cell lines. Now for storage disorders, you would also have a history of floppiness, delayed milestones, seizures. So what storage disorders are we trying to look for? We're trying to look for Gaucher's, Niemann-Pick, glycogen storage, because these are the ones that can present with abdominal distension and anemia, but they will also have these associated complaints. So this kid doesn't have any history of floppiness or delayed milestones. And lastly, whether there's history of yellowish discoloration of eyes, skin, basically jaundice, and dark colored urine. So this is to look for jaundice because of renal failure. So when you have, liver failure, when you have liver failure with portal hypertension, that again can present with anemia and HSmegaly. So these are the set of questions that you will ask in terms of your differentials when you're dealing with anemia with HSmegaly. Now, let's say the patient only presented with anemia, okay, which was again very much possible. Probably the mother never noticed the abdominal distension, or it's something that might have gone unnoticed. So it was never a part of the chief complaint. So let's say we're only dealing with anemia. So other than these questions, what are the other set of differentials you will be asking for only anemia? So whether there's history of passing worms and stools for hookworm, okay, that again leads to blood loss, which can cause anemia. History of pica. Now, pica can be seen in iron deficiency, worm infestation, and lead poisoning. All of this can lead to anemia. Whether there's history of blood loss in stools, whether they're black tarry stools or blood and vomitus, for any GI bleed, which is leading to anemia. History of oliguria or anuria, because again, CKD is associated with anemia of chronic disease. And last but not the least, history of diarrhea with oily stools for malabsorption. So malabsorption again impairs your iron absorption and can also lead to anemia. So these are the set of questions that you will be asking if you think you're dealing with anemia. So all of these are important, whether or not the mother gives you a history of abdominal distension, because anemia has still been the chief complaint. And you might have cases where the mother or the informant doesn't give you a history of abdominal distension. Okay, so next point that we're going to talk about is the past history. So whether there's any history of hospitalization or blood transfusions in the past. So this kid doesn't have any of that. The first time the mother noticed that she was pale was at 8 months of age, and before that the child has been apparently all right. Before I go to this slide, let's just go to the next one, wherein I'm talking about treatment history. Now, treatment history becomes very important because this patient came in with pallor, with breathlessness. So there is something something pressing, and there's something that needs to be taken care of immediately. So the child was admitted to the hospital. This is again history, so this is what the mother's going to tell you, that the child was admitted with these complaints in the hospital and was given 2 blood transfusions since admission. Now you are taking the history, say on day 3 of admission. So the child has already been admitted, has received 2 transfusions, and according to the mother, the breathlessness has improved since admission. So most likely the blood transfusion has relieved the breathlessness and she has improved. So most likely it was anemia with congestive cardiac failure that led to like severe anemia with the breathlessness. And after the transfusion, the child has improved. So this is what treatment history gives you a lot of information as to what has happened since admission, whether there has been improvement or not, and what really led to the improvement. Okay, so treatment history in this case was that it was blood transfusion which improved the condition. Now, when I'm talking about past history, let's take the second scenario wherein the patient is a known case of beta thalassemia. So in that case, when you're looking at the past history, you will say that this case is diagnosed with a hematological disorder at say 1 year of age. Sorry. And along with that, when you're talking about a known beta thalassemia, the next few set of questions becomes very important because the mainstay of treatment in beta thalassemia is your repeated regular blood transfusions. Okay, so then you start about asking details about blood transfusion, that at what age was the child first transfused? What is the frequency of transfusion? Like usually they receive blood transfusion every 3 to 4 weeks, depending on the pre-transfusion hemoglobin and other uh, factors that we determine. So how often does a child require blood transfusions? Has there been a change in the pattern of blood transfusions recently? So let's say he was requiring transfusions every 4 weeks initially, but for the past few months he's requiring transfusions every 2 months. That means the frequency of transfusion has increased, which can indicate hypersplenism. Okay. So whether there has been a change in the pattern of transfusion recently, number of bags of blood he or she receives per visit or per transfusion. So older kids with more weight will require more number of bags as compared to younger kids. And last question is, when was the last transfusion received? So say he's coming to you today for the next transfusion. It's important to ask when was the last transfusion received. One is to know the compliance as to how often he's been asked to come and whether or not they're following up that schedule, and whether or not he is requiring transfusions more frequently than he should. That again points towards hypersplenism. So these are the set of questions that are extremely important when you have a known beta thalassemia who's coming, and these are the questions you will ask in your past history. Other than that, you'll also ask for any other testing, whether a bone marrow has been done, a genetic testing has been done. So nowadays, a lot of beta thalassemics, when we're diagnosing them along with the HPLC, we're also sending a genetic testing for thalassemia. Also ask whether the parents have been tested or not. So if you have a beta thal major, the parents have to be carriers. So that's again another important question that you need to ask, whether the parents have been tested, because in case they are planning another pregnancy, then you don't want that other kid to also have beta thal major. So your set of counseling and investigations in the antenatal period, etc., will kind of change if the parents are known beta thal carriers. Okay, so that is another important question. And whether there's history of jaundice. Now, usually thalassemics don't have jaundice, or the jaundice is very less severe. But if you have a beta thalassemic who's you know has had a history of jaundice, then the reasons could either be because they have associated infections, like you have hepatitis B and C, which can be transmitted because they are on repeated blood transfusions of parenteral infections. Sometimes when the blood transfusion happens along with some minor incompatibilities. So you have the minor blood groups like Kell, Duffy, etc. So when the blood has not been matched accurately with those minor blood groups, that again can lead to ongoing slow chronic hemolysis, which can present with jaundice. And even under transfused patients who have ongoing hemolysis can have jaundice. So three common causes of jaundice in beta thals is under transfusion, infections like hepatitis B and C, and if they have ongoing hemolysis because of mismatched minor blood groups. So this is the importance of asking for detailed history in past in a known beta thalassemic, and we looked at what you will ask if it's a new case. We saw treatment history for a new case. When you're talking about treatment history for uh, a known beta thalassemia, again, along with blood transfusion, another mainstay of therapy in beta thalassemia is iron chelation. It's extremely important because the rate at which we're giving blood transfusions, the body is not able to eliminate all the extra iron, which starts getting accumulated in the body. And iron is known to be toxic. We look at iron toxicity as we go ahead in the discussion. But if not treated well with iron chelators, then it can lead to a lot of side effects and a lot of deb- uh, debilitating conditions, whether it's growth retardation, endocrinopathies, cardiac dysfunction, etc., because of the iron overload. So, iron chelators becomes very important. What age was iron chelator started? What is the name of the medication? Whether they are compliant or not with that, and how are they taking it? So, how are they taking it becomes extremely important, specifically when we are dealing with iron chelators, uh, which is the most common one that we use is the oral medication, which is Desirox or Deferacerox. Okay, so Desirox is what is the brand name. That's what the patient will know, as what the name of the medication is. So how is Desirox supposed to be taken? It needs to be dissolved in water, about 100 to 200 ml of water, or orange or apple juice. Obviously cheaper option is water. but you can use any of these conditions. I mean, any of these dissolving liquids. You have to dissolve it in a plastic container, not a steel container, and it needs to be taken empty stomach or at least 30 minutes before a meal. So the way you take Desirox is it needs to be dissolved in water in a plastic container, not a steel container, and needs to be taken empty stomach. You can't swallow the tablet or you can't chew the tablet because it's that's not going to work. So whenever Desirox is prescribed to a thalassemic for iron chelation, these instructions are very important that need to be given to them as to how they're supposed to take the drug so that you know that the drug is going to work. Okay, so iron chelator questions pertaining to unknown beta thalassemics is extremely important. Whether they're taking any other drugs like folic acid, hydroxyurea, vitamin C, and whether there is any history of surgeries. So, like we saw, hemolysis, hemolytic anemias, have gallstones, uh, have gallstones, have hypersplenism, have splenomegaly. So they could have undergone a cholecystectomy or splenectomy. So history of abdominal surgeries is important. Now, history of complications in a known beta thalassemia. So you can have growth impairment, auditory and visual complaints. So auditory visual complaints can happen because of side effects of the iron chelators that are used. So these questions need to be asked every time they come for blood transfusions as to whether or not they're having, any visual complaints, any color vision problems, difficulty with acuity or field of vision, whether any tinnitus, ringing, hearing impairment, all of these questions become very important. And obviously, they have to be associated along with formal testing. So you need to do yearly ophthalmic and auditory evaluations, etc. And history of endocrine abnormalities like hypothyroidism, hypogonadism, diabetes. So these are the most common endocrinopathies again that you see in beta thalassemia because of iron overload. So there are certain organs in the body that have a higher predisposition to be affected because of iron overload. The most common one is the liver, following which you have the heart. So iron deposits primarily in the liver. Once that is saturated, it starts moving over to the heart, and then along with that, endocrine organs. So you have the pituitary, the parathyroid, etc. So when you have the pituitary gland being affected, it inhibits release of all the hormones which lead to hypothyroidism, hypogonadism. It also affects the pancreas. So you have diabetes mellitus. So all these are endocrine problems that happen because of excess iron overload in somebody who's not been chelated well and is receiving regular blood transfusion. So these are the set of complications and questions related to that you'll ask for. Now, when you come to antenatal, natal, and neonatal history, there are certain questions that are pertinent to this particular case. I'm only going to be discussing that. But your format of taking your antenatal, natal, and neonatal history is like any other case. So you'll look at the the antenatal history, the first, second, third trimester, birth history, and neonatal history. But when I'm looking at for specific questions, one important question is what is, say it's the second or third child, it's not a primary mother. First question important is your interpregnancy interval. So if she has conceived within 2 years again, and the mother herself is malnourished, is there's not been enough time for the replenishment of nutrition and iron stores. Then again, if the mother is anemic, there's a chance that the child is going to be anemic because there is lesser, transmission of your nutrition and iron stores from the mother to the child. Whether there's history of blood transfusion or iron transfusion in the antenatal period in the mother, again points towards maternal anemia, which for the same reason again can lead to childhood anemia. Third one is fever with rash. So your torch infections can also present with rash, anemia, hepatosplenomegaly. So you need to ask for history of fever with rash in the first trimester predominantly for torch infections. So this is just a practical question as to whether we can pick up beta thal carrier states with the help of a simple CBC. So, is it possible that when a mother is coming for an antenatal checkup, is there anything on the CBC that can tell us that, okay, probably she could be a beta thal carrier and maybe she requires investigation? Because, see, beta thal carrier patients are otherwise asymptomatic. They will not have features of anemia and anemia leading to clinical symptoms because anemia is pretty mild, so they might have gone unnoticed. But if the mother herself is a beta thal carrier and the father also is a beta thal carrier, then there's a 25% chance that the baby is going to be beta thal major, a 50% chance that the child is going to be a carrier, and a 25% chance that the baby is going to be just normal. Okay. You don't want that 25% chance of having a child with beta thalassemia. So just uh, you know uh, uh, a very practical question as to whether your simple CBC done in the antenatal period can help you, give you some hint or some clue that probably this mother could be a beta thal carrier. Is there anything that we can see on CBC? Any indices, any index that we can look for on the CBC? So put it down in the chat box. Okay, yeah, you're right. Menser's index. What exactly is Menser's index, and how do you interpret it? And other than Menser's index, is there anything else that we can see? Okay, that's okay if you don't remember. No, okay, we will be discussing this in the discussion ahead, but just keep this in mind that when you have, these are the things that, because it's not possible to screen every mother in pregnancy, especially if she's asymptomatic or a beta thal carrier stage, right? So let's see in the discussion if a simple CBC can help us with this. Other than that, a very important question in your antenatal history is whether there's history of neonatal jaundice. Now, causes of neonatal jaundice, again, specifically pertinent to this case. So, your hereditary spherocytosis, G6PD deficiency, and alpha thalassemia, all of these can present with hemolysis and jaundice in the neonatal period, severe enough to even require blood transfusions or even exchange transfusions, depending on how high the bilirubin goes. So, when you have neonatal jaundice, again, obviously, the most common cause is physiological jaundice. But when the jaundice is severe enough that it required intervention, it could point to underlying hemolytic anemias like I said, hereditary spherocytosis, G6PD deficiency, and alpha thalassemia. So this is a very important question that you should ask for. Again, like we saw the first slide, at the age of presentation, whether they present in the neonatal period or later in infancy, will again help you, give you clues as to what diagnosis you're dealing with. Now, developmental history in this case was normal, but again, you need to take a detailed history with respect to all the four domains. I'm not going into those details. Dietary history, now mine is a 10-month-old child who was exclusively breastfed till 8 months of life and then has been started on some amount of complementary feeding. So you need to take the breastfeeding history. Now, if the child is coming with breathlessness and has also history of feeding difficulty, then that is something that you need to ask for. That how does she feed? How often? Whether there's suck rest suck cycle, whether there's feeding difficulty, etc. Complementary feeding, because again becomes very important when you're dealing with anemia. So you want to really know whether the kind of right nutrition has been introduced at the right age and whether or not the child is receiving all that it should or is nutritionally deprived, which is causing the anemia. Okay. So obviously, like any other case, you'll calculate the protein and calorie intake expected and the deficit. And when you're dealing with unknown beta thalassemics that we know have a risk of iron overload. Another interesting question that you can ask for is whether the vessels that are used for cooking are made up of iron or not, because you don't want to like further overload them with more iron. They anyways are at a risk of iron overload. Now, cooking in iron vessels again is going to increase the risk of iron overload. So that's another interesting question that you should ask in patients that have beta thalassemia and are like the second scenario when they're coming to you for a regular blood transfusion and follow up. Immunization as per the national immunization schedule. In splenectomized patients, we give them vaccines against the encapsulated organisms. So specifically as per Hib, pneumococcal, and meningococcal, especially for those who have undergone splenectomy. You don't need to ask it for every other patient, but if you know that there has been an abdominal surgery, the spleen has been removed, then it is extremely important to ask for these questions, because splenectomy, like we all know, impairs the opsonization and clearance of these organisms, and that's the reason why it's always important to immunize them against these encapsulated organisms. Family history, very important to always draw a 3-generation pedigree chart and ask for history of blood transfusion in the family, any hemolytic disease, somebody in the family who has a known hemolytic disease requiring blood transfusions, whether there's history of very important gallstones, jaundice, any abdominal surgeries. Abdominal surgeries could either be splenectomy or cholecystectomy. So whether anybody in the family, so it could be a near family or it could be the slightly extended family, the first degree relatives, second degree relatives that also have received or also have undergone any surgeries in the past, and history of infant death. So what happens is many a times these patients go undiagnosed, like I said, especially if they're living in the hilly areas where they do not have access to medical services that easily. You could have history of infant death that, probably the child just became pale and started having difficulty breathing. And before we could take him to the hospital, the child expired. So probably it was, severe anemia, severe pallor, anemia with CCF and something of that sort. So many a times you might have a history of infant death, and but you might not really have a cause as to what happened. There could be multiple reasons for infant death. I'm not saying it has to be related to the hemolytic anemia, but if you have it, one question is you should definitely ask for specifically infant death, and secondly, if you have a history, whether it's the mother's side or the father's side, always try to dig into what exactly happened that led to the death. You might be, lucky enough to get a, a history that points towards something, or it is possible that the parents or the informant doesn't know. But irrespective, you should try and take a history, whether or not you have your luck in getting it adequately or not. Next, socioeconomic modified Kupuswami. You guys are pro at this. I'm not discussing that. And like I always keep reiterating, KAP, knowledge, attitude, and practice. So whether the parents know what the child is having, especially in beta thalassemia majors, what do they understand about the disease? What is their attitude? How are they practicing what they're supposed to? So whether they're following up regularly for blood transfusions, whether they're doing the blood investigations that we ask them to do regularly, whether they've had their MRIs and echoes, etc., done, whether they're taking iron chelators, whether they're compliant with it, whether they're taking it the right way. So knowledge, attitude, practice becomes extremely important in any chronic condition. So now, if I have to summarize this case, okay, so this is a 10-month-old child born of third degree consanguineous marriage, a resident of, say, Mumbai, hailing from Nagpur, belonging to the Buddha community, who was presented with chief complaints of pallor noticed by the mother since 8 months of age and easy fatigability, abdominal distension since 9 months of age, and breathlessness since 1 week back. Is a case of anemia with congestive cardiac failure, most probably, that improved with the blood transfusion and is also having abdominal distension. So when I'm looking at this, when you have anemia with abdominal distension, most likely I think my set of differentials will be hemolytic anemia and nutritional anemia. Okay. Now, why have I put hemolytic anemia first, followed by nutritional? It could be, you can swap it over the other way. But 10-month-old child presenting with, anemia severe enough that it's causing PCF and requiring blood transfusion is, I would say, slightly less likely because, she's also been started on complementary feeds at 8 months of age. So I don't expect that the anemia would be that severe enough that it's causing PCF and she's required like 2 blood transfusions since admission. The second thing is when I'm dealing with anemia and abdominal distension, so I think it's more in terms of anemia with hepatosplenomegaly. Now, hepatosplenomegaly can be seen in about 30-40% patients of megaloblastic anemia, but it, points more towards some other cause of the anemia with the abdominal distension. So that's the reason why I'm putting hemolytic anemia and also looking at the age, which is when she presents at about the symptoms started when she was 8 months of age. Now, like we discussed, hemolytic anemia is the most common one in our country, being beta thalassemia major, that presents at about 6 months to 2 years of age. I would like to put that as my first differential, which is going to be hemolytic anemia. In that, I would say beta thalassemia major. If I were asked other differentials under hemolytic anemias, I would either say next thing that I would say would be hereditary spherocytosis. Now, hereditary spherocytosis per se again has a wide spectrum of presentation. They can present with severe jaundice in the neonatal period requiring exchange transfusion and blood transfusion. They might go unnoticed, even up till childhood or adolescence. But hereditary spherocytosis usually has jaundice, which is severe enough. Okay, now this patient of ours, we did not really have any obvious jaundice on history at least. So that's the reason why beta thal major, because of the chief complaints and the age of presentation and the incidence being the most common hemolytic anemias, my set of differentials would be hemolytic anemia and followed by nutritional anemia. Now, why not the others? So other conditions or other differentials of anemia with HSmegaly that we saw were malignancy, infections, and storage disorders. So these are again questions that can be asked in your viva, that why have you not put the other differentials in your, 3, 4, 5? So we've seen why we've ruled out malignancy, storage disorders, again, because there's no history of any floppiness, seizures, delayed milestones, etc. And infection, because there's no history of fever with chills, etc. So that's the reason why I am not considering those as my, you know, differentials for this particular case. So that kind of concludes the summary on the basis of history. Before we move ahead with the examination, does anybody have any questions with history? Then we can discuss it right away. Is there anything that you didn't understand, you want me to repeat? We can go over it again. If not, we can move ahead with the examination.
Ma'am, can you repeat why hemolytic anemia and then nutritional? Like, why did you
Right. So I
different?
said, okay, so if you have anemia with hepatosplenomegaly or abdominal distension, that points more in terms of, or favors more of hemolytic anemia, because in nutritional anemia, you definitely will have pallor and anemia. But abdominal distension is not a very obvious finding in your nutritional anemias. But having said that, in megaloblastic anemia, about 30 to 40% patients can still have hepatosplenomegaly. Okay, so that's why I'm not completely ruling out nutrition anemia, because when you look at only anemia, the most common cause of anemia in the country is nutritional. Okay, so it could be iron deficiency, it could be dimorphic anemia, it could be anything. So I'm not completely ruling out nutrition anemia, but because looking at the age of presentation, so the iron stores for the first 6 to 7 months is enough for the child. Uh, Irrespective of, I mean, obviously, first 6 to 7 months, the child is going to be breastfed. Okay, so whether or not the mother is malnourished, but still for the first 6, 7 months, you will not see kids presenting with severe anemia because of iron deficiency. They start presenting by about 7 to 8 months, and you know, severe enough that it requires blood transfusion and is causing CCF is by around 1 year of age. Now, in this patient, although she was breastfed till about uh, say 8 months of age, but then has been started on complementary feeding. More details about the diet will tell you whether or not the diet is, adequate in terms of the calorie, protein, and the micronutrients. But looking at the age of presentation, at 8 months, presenting with severe anemia, with CCF, requiring blood transfusion, and abdominal distension. Abdominal distension is not something that you will commonly see in nutritional anemias. It is more commonly seen, I would say, in hemolytic anemias. And with the other history, that it's a consanguineous marriage. She's a resident of Nagpur, belonging to a community that has a higher prevalence of hemoglobinopathies. I would put hemolytic anemia as my first differential versus nutritional anemia. And again, hemolytic anemia commonly presents at this age of, say, 6 months to 2 years. And in that, the most common one is going to be your beta thalassemia major. Okay. So that's the reason why I've said hemolytic anemias is my number one differential. In that, I will say beta thalassemia major. And the second one I would say would be nutrition anemia. So I hope that answers your question.
Yes, ma'am. Thank you.
Okay. So I don't see any other questions. So we'll move ahead with the examination. If you have any, just note it down. We'll take it at the end. So in general examination, like any other case, what is the general condition and posture of the child? So if the child is having tachypnea, breathlessness, is in CCF, we tend to keep them in a slightly propped up position, say the head up 30 or 45 degrees. If not, whether the child is comfortable lying comfortably in the mother's lap, so general condition and posture. Temperature, heart rate, blood pressure, uh, respiratory rate, and your CRT and peripheral pulses. So that's basically about the vitals. Anthropometry, again, important here because we're dealing with anemia. So with anemia, anthropometry in general is a very important thing in any pediatric case. But specifically when you're dealing with anemia or nutritional cases, your anthropometry becomes very important. And like I keep telling every time, you always obviously will look at the observed, so you will measure this, you will calculate the expected, and always remember to have an interpretation of your anthropometry, whether it's acute malnutrition, whether it's chronic, whether it's acute on chronic, whatever it is. So interpretation is something that the examiner is going to be most interested in, and you should always have your interpretation ready at the end of your anthropometry. So those numbers and digits, से भी ज़्यादा important है your interpretation of anthro. Now, head to toe examination. So, first is your pallor, edema, lymphadenopathy, icterus, cyanosis, and clubbing. So, again, in this case, pallor becomes most important and followed by icterus or jaundice. Okay. So, how do you look for pallor? So, an easy way of doing it is comparing your hand with the patient's hand. So, you put the patient's hand on your, I mean, patient's palm on your palm and see for, the difference in how pink your hand should be and how white the patient's hand will be if you're dealing with, pallor and anemia. Important points to remember while doing this is that you should not have pallor yourself to be able to compare. And don't overstretch the hand. Okay, if you overstretch the hand while putting the palm on your hand, it's going to cause like pseudo anemia. So just gently put the patient's palm on your palm and then compare the difference in color. Now, with respect to the face, you have particular hemolytic faces, also called chipmunk faces, that you see in thalassemics. Okay, so this is what it looks like, where they have frontal bossing, parietal bossing, they have malar prominence, they have, impaired dentition. So flat nasal bridge, frontoparietal bossing, malar prominence, prominent jaw, malaligned or misaligned teeth. This is a typical phase that you will see in hemolysis or in those with chronic hemolytic anemia, which is a feature of your, I'm sorry, it should not have been extra. It is intramedullary hematopoiesis. Okay, so intramedullary hematopoiesis results in expansion of all these bony prominences and bony spaces, which gives them this typical chipmunk or hemolytic faces. Your extramedullary hematopoiesis, when I say it, refers to basically hepatosplenomegaly. So this basically, because it's the bones, it's intramedullary. So, I'll change this before sending you the videos. But remember, this is what hemolytic facies looks like. And with respect to this, if you look at the hyperpigmentation, so there's gingival and the skin hyperpigmentation because of excess iron deposition. Okay, so when you have hemosiderosis, when you have excess iron deposition because of chronic blood transfusion, all of this extra iron can start depositing in the skin and subcutaneous tissue, which starts giving this impression of hyperpigmentation. And that is again something that you see in somebody who's receiving chronic blood transfusions. Now, oral cavity for stomatitis, cheilitis, glossitis, and gum bleeds, all of this for your nutritional causes of anemia. Gum bleeds, again, if you have associated thrombocytopenias, like if you think you're dealing with malignancies, or hypersplenism severe enough to cause thrombocytopenia, you can have associated gum bleeds. Spine and genitals, like any other case, skin hyperpigmentation, we just saw hemosiderosis, and again, petechia purpura to look for thrombocytopenias. So that's about head to toe examination. Let's quickly move to GI. So an inspection. So shape of the abdomen was distended, flanks were free. Umbilicus was shifted downwards and slightly transversely stretched. There were no dilated veins, scars, sinuses, or visible pulsations. All the quadrants were moving adequately with respiration. Hernial orifices and genitals appeared normal. So inspection-wise, what I only found was that the abdomen appeared distended and upper part of the abdomen looked more distended. The umbilicus was shifted downwards and was slightly stretched. On palpation, on superficial palpation, no local rise in temperature. Abdominal circumference at the level of umbilicus, always remember to measure this. And on deep palpation, extremely important points in this case is your palpation of liver and spleen. Now remember what all points you need to keep in mind while palpating and while presenting. So what was the size of the liver on palpation? So you measure it in centimeters from below the right subcostal margin. Okay, so let's say the liver was 7 centimeters below the right subcostal margin. which was firm in consistency, had uh, rounded borders, was smooth in surface, was non-tender, and moving with respiration. So whenever dealing with any organomegaly, like basically liver and spleen, always remember to mention the size, consistency, border, surface, and tenderness. These 5 points becomes very important. Only then your entire description of organomegaly is, considered to be complete. So, so like I said, this case, the liver was 7 centimeters below the right subcostal margin, firm in consistency, rounded borders, smooth surface, and non-tender, moving with respiration. Whereas the spleen, on the other hand, was measuring about 10 centimeters in size. Uh, Again, firm in consistency. I could feel the splenic notch. Surface was smooth, non-tender, and moving with respiration. So remember the 5 points that you need to describe when you're describing either liver or spleen on palpation. And all of these will give you some kind of idea as to what you're dealing with. Like, let's say if it's a hard spleen or a hard liver, whenever you have something that's hard to palpate or hard to touch, it points more in terms of a malignancy versus something which is, firm. And if you're looking at soft, so let's say if you had like a tender hepatomegaly because of congestive cardiac failure, it would have been a soft liver that was tender to palpate. But here I'm talking about the consistency being firm, non-tender. So each and every point of your palpation will give you, some kind of idea as to what probably is the cause for the organomegaly. Now, once you say that, you have splenomegaly, there's a high probability that the next set of questions will be that how will you palpate the spleen? So there are three different methods. The first one, routinely you start from the right iliac fossa. Always remember that you start palpating the spleen. Although the spleen is located on the left side, you always start palpating from the right iliac fossa, because when your spleen enlarges, it enlarges from the left hypochondrium to the right iliac fossa. So like that, diagonally, or can say, yeah, that's the direction in which the spleen enlarges. So first is you start, the patient is supine, start from the right iliac fossa and start palpating towards the left hypochondrium. So this is method number one. Method number two is you turn the patient to the right lateral position. So you're standing on the right side of the patient. You turn the patient towards your side and try insinuating your fingers below the left subcostal margin. So your left hand is, giving support to the rib cage, and your right hand is trying to insinuate the fingers under the left subcostal margin. This is usually done when the spleen is, not that enlarged that you're able to palpate it with the first method. So trying to see if, in this, whether the spleen, the tip of the spleen is hitting your fingers or not. So that is method number two. And the third is called the hooking method. So this is slightly different when you do it. The patient is meant to lie supine. You go to the left side of the patient and you're standing on the head end facing the foot end of the patient. Okay, so your patient is supine. You're on the left side of the patient. You are at the head end of the patient facing the foot of the patient. And then with your left hand, you try to hook your fingers under the left subcostal margin and try to feel for an enlarged spleen. Okay, because this is the reason, the region where you have the spleen and the spleen is not significantly enlarged. Probably this method will help you, again, try to feel the tip of the spleen on your fingers. So like I said, when you have a spleen, it enlarges in this direction. Okay, so from your left hypochondrium to the right iliac fossa. And that's the reason why whenever you're starting to palpate the spleen, if the examiner asks you to do it in front of them, like, show me how you palpate it, even if you know that the spleen is very small and you will not find it on palpation from the right iliac fossa, still, when you're showing it, when you're demonstrating a sign, always start palpating from the right iliac fossa and then go towards the left hypochondrium. Keep this in mind because this is what they look for, and you should not be making a mistake in this simple thing, because probably you know how to do it and you've done it and you didn't find anything when you were palpating from the right iliac fossa, but when asked to do it, remember to always, always, always start from the right iliac fossa. Now, next question that will be asked is, how do you differentiate a spleen from a kidney on palpation? So this is again a very favorite practical viva question. So when you have the spleen, you'll be able to feel the splenic notch, which is the sharp edge of the anterior end of the spleen. The spleen is non-bloatable. It moves with respiration. It enlarges towards the right iliac fossa, even large enough to cross the umbilicus, and the loins appear free and resonant. Whereas if it's a kidney, It's going to be more rounded. You won't feel like a sphenic notch. Um, Bimanual palpation, kidneys are going to be ballotable. Okay, doesn't move with respiration because it's a retroperitoneal structure. It enlarges in the respective lumbar fossa, so it's not going to cross the umbilicus. It's not going to go from one side of the body to the other. And on percussion, the loin, I mean so your loin appears dull and full because that's where your enlarged kidney is sitting. So that's how you differentiate kidney and spleen on palpation. Remember these points. Again, questions that can be asked you in your vivas. Percussion, liver span becomes very important. So you do a tidal percussion. So we've already measured the liver span on, I mean, the amount of liver that can be palpated from the right subcostal margin. But there might be, some part of it that's lying under the rib cage that you've not measured. So your tidal percussion is very important for your liver span. And obviously, because you have abdominal distension, whether or not you have any free fluid. So you do your horseshoe, shifting dullness, and fluid thrill to look for any free fluid. Auscultation, whether or not bowel sounds were heard, which more likely should be just normal in this case. Other systems, again, important is CVS, because especially this patient presented with anemia and pallor and breathlessness, so maybe was in CCF. Okay, so usually you will have S1, S2 normal, but sometimes you might have a soft systolic murmur, your hemic murmur, or your murmur of anemia, which is usually going to be less than grade 3 or less than equal to grade 3. And so that might be a normal finding. CVS examination might just be absolutely normal in other cases. So just keep in mind that you might have, you might be able to auscultate a murmur, which is your hemic murmur. RS and CNS examination should be ideally within normal limits. So now this is a 10-month-old girl child, resident of Mumbai, hailing from Nagpur, belonging to the Buddha community, born out of third-degree consanguineous marriage, who presented with chief complaints of pallor, easy fatigability, abdominal distension, and breathlessness, with my examination findings suggestive of pallor, severe hepatosplenomegaly, and depending on, let's say this patient also had frontoparietal bossing. Okay, so these were the findings that I found in this patient with who was immunized, up to age developmentally normal, and let's say anthropometrically she had severe acute malnutrition. Okay, so depending on your anthro findings, whatever your anthro findings might be, it might be normal, it might be chronic, it might be acute on chronic, whatever it is. That's why I said your anthropometry becomes very important, especially when you're dealing with anemia, to to give you a little more information of whether or not it could be nutritional or not. So with the summary, so summary is basically how you summarize your entire case. You give your chief complaints, you give your positive findings on examination, and any other things that you would like to emphasize on. And then once you've said summary, you move to the diagnosis. So this is a case of, I feel, anemia with hepatosplenomegaly. The cause most likely being hemolytic anemia. In hemolytic anemia, I'd say most likely transfusion dependent beta thalassemia. So earlier, the nomenclature was beta thal major, beta thal minor, intermediate, etc. Now the nomenclature has changed to just two things: transfusion dependent thalassemia and non-transfusion dependent thalassemia. So because the child is presenting at a young age of 8 months or 10 months, whichever one you want to consider, and has come with anemia and CCF with hepatosplenomegaly requiring blood transfusions. This definitely looks like a transfusion dependent thalassemia. So my diagnosis at the end of history and examination would be that this is anemia with hepatosplenomegaly, most likely due to hemolytic anemia. In that, I'd say transfusion dependent thalassemia. So this is how we've gone over the history, examination, and then come to a diagnosis. So does anybody have any questions on the examination and the diagnosis part? Is there anything that you haven't understood and you want me to go over, then I can do that. If not, we can move ahead with the investigations. Okay, so now the next question would be that, okay, you've taken a history examination, you think this is anemia with hepatosplenomegaly. What are the set of investigations that you would want to do? So first thing definitely would be a CBC with a peripheral smear and a reticulocyte count. Remember, don't just say CBC, because along with the CBC, something that gives you a lot of information is undervalued as an investigation is your peripheral smear and your reticulocyte count. So what do you expect to see in a CBC report? So definitely anemia. What type of anemia? Microcytic hyperchromic anemia. In the peripheral smear, I can have anisopoikilocytosis, teardrop cells, target cells. So teardrop cells, target cells, all of these point more towards hemolytic anemia. So what do they look like? So this is microcytosis. So let's see, this is what a normal RBC should look like. This one. Okay, this is what a normal RBC should look like. Now look at this RBC. It's smaller and it's, you know, microcytosis. And if you look at the color, it's not very obvious here, but it's, you can say hypochromasia. If you look at these cells, this is like, they look like a target, like your dartboard. These are the target cells and these are the teardrop cells. They look like a tear. So teardrop cells, target cells point towards hemolytic anemia. Anisopoikilocytosis, when I say that, it means the different shape and size of the RBCs. So anisopoikilocytosis can be seen in iron deficiency anemia more. Again, it also can be seen in thalassemia, but definitely it's more in iron deficiency. So these are the pictures that you will see on a peripheral smear of a microcytic hypochromic anemia. Now, having said that, you can be asked, what are the causes of microcytic anemia? So you have iron deficiency anemia, you have beta thalassemia trait, you have lead poisoning, and sideroblastic anemia. These are the common causes of uh, yeah. So someone's asking, ma'am, do we mention Hackett's grading in spleen palpation? Yes, you're not wrong. You can definitely mention it. So yes, you can mention. Yeah. Okay. So this is what you see in your um. Sorry, this is what you see on a peripheral smear in uh this anemia with hepatosplenomegaly. Along with that, when you look at the RBC indices, you'll have low MCV, low MCHC. In this case, because I think it's beta thalassemia. The next thing that you look for in a CBC report is a red cell distribution width, or a RDW. Now, in thalassemia, your RDW will be normal versus in iron deficiency, where your RDW will be elevated. Okay. And along with that, what is important is a Menser's index. So, what is Menser's index? It's MCV upon RBC. Okay. So, in both these conditions, basically, Menser's index is used to differentiate beta thalassemia from iron deficiency anemia. So both of them will have microcytic hypochromic anemia, but the RDW in beta thal is going to be normal, whereas the red cell distribution width is going to be higher in iron deficiency because they have anisopoikilocytosis. That means they have a more wider distribution of RBCs of different shapes and sizes. So that's why the width distribution width increases and you have higher RDW in iron deficiency anemia. The RBC count, although reduced in both, will be reduced more in iron deficiency anemia as compared to beta thalassemia. So when you look at the Menser's index, it's MCV upon RBC. Now MCV is going to be decreased in both, okay, because there's microcytosis, but the RBC in anemia is going to be reduced more as compared to that in thalassemia. Sometimes you might also have a normal RBC count in thalassemia. Okay, so RBC count can be normal or can be slightly reduced, but definitely if you have iron deficiency anemia, you will be having a low RBC count. So when your RBC count decreases, your denominator decreases, your overall uh, fraction is going to increase, right? So iron deficiency anemia, the Menser's index is more than 13, whereas in Thal, the Menser's index is less than 13. So that is the significance of your Menser's index, which is MCV upon RBC. If you go back to my question that I asked, is there any simple CBC test that you can use to say that, oh, probably this mother, this pregnant lady could be a beta thal carrier, is if the mother has microcytic hypochromic anemia. And if you look at the Menser's index and say it's less than 13, it goes more in favor of, a thalassemia carrier rather than her being iron deficient. Although the most common cause of anemia, even in pregnancy, is nutritional anemia. But this is a crude way of, trying to differentiate only on the basis of a simple CBC report using the Menser's index, whether it could be an IDA or it could be a THAL trait. Okay. So along with that, because this is hemolytic anemia. That means you have the blood being destroyed peripherally, as a result of which the body is trying to compensate by trying to produce more and more immature RBCs. So your reticulocyte count will be increased. So hemolytic anemia, always a retic count is increased because your body, your bone marrow is trying to compensate for the anemia by trying to produce more and more. One more interesting thing that you will see in a CBC of a thalassemia is it's very important to look for the WBC count. Now, many a times you will have WBC as high as 50,000, 70,000, even 1 lakh. Okay. Now, whenever you look at the WBC, along with the total WBC count, always look for nucleated RBCs. So if you have ever seen a CBC report of a THAL patient, you might have a very high WBC of say 50,000. But along with that, at the border, at just below that, many times they write NRBCs, which is your nucleated RBCs. So nucleated RBCs say are 35,000. So your uh, total actual WBC count is 50 minus 35, which is 15,000, which is normal, right? So if you see 50,000 WBCs, you might start thinking in terms of, oh, is this leukemia? But whenever you have this and you have a suspicion that probably this is thalassemia, always look for nucleated RBCs, because what happens is the nucleated RBCs on the Coulter machine. So when you run your blood, uh, on the CBC, the hemogram machine, the machine, see, basically it's a machine, okay? It doesn't differentiate what cells it is because it doesn't see it, it just measures it. So when you have nucleated RBCs, they're of the same size as that is WBCs. Okay. So the machine calculates those nucleated RBCs as WBCs, and that's the reason why the WBC count that you get on a CBC on a hemogram, which has not been seen on a peripheral smear, will be very high because the NRBCs are calculated as WBCs. But when you have such a high WBC report, the pathologist or the hematologist always confirm it with the peripheral smear. And on the peripheral smear, they're able to see the nucleated RBCs, which look distinctly different from a WBC. And that's when they write that the NRBCs are these many. So then you're able to say, okay, that the overall WBC count seems high, but that's the reason. The reason behind that is that there are a lot of nucleated RBCs, and that's why the effective WBC count will be normal. So that is another interesting thing that you encounter on a CBC. Along with that, platelet count, it can be normal, or if there's massive splenomegaly, hypersplenism, you might also have thrombocytopenia. So we saw a CBC. Now, how do you confirm the diagnosis? So we've on the basis of CBC, we know it's a microcytic hypochromic anemia. We know the indices, the reticulocyte count, the peripheral smear, and the Menza's index, along with the other parameters like WBC and platelets. Now, how do you confirm diagnosis? Obviously, the best way is to perform a HPLC, which is a high performance liquid chromatography. That is the test that is done to confirm your diagnosis. So let's look at what an HPLC report looks like. So when you have any child who's normal, so let's assume that the child is say 1 year old. So this basically pattern is for somebody who's almost a year old, because like I said, initially for the first 6 months you will have fetal hemoglobin, which slowly transitions to adult hemoglobin as the child grows. So, or normally let's take an adult or maybe a 3 year old. So your major fraction of your hemoglobin is going to be HbA. So that's going to be as high as 96 to 98%, with less than 1% of fetal hemoglobin, and HbA2 is going to be about 2 to 3%. So this is what a normal configuration of a hemoglobin on an HPLC report looks like. Now, if you have beta thal major, okay, there's going to be no HbA. Okay, why? Because HbA, like we discussed, is 2 alpha chains and 2 beta chains. When you don't have beta chain production, you will have, you will not have HbA. Okay, so HbA will be as low as 0 or maybe even less than 5%. But your HbF is going to be elevated because it's trying to compensate for the deficiency. And HbF is alpha 2 gamma 2. And you have an abundance of alpha globin chains because none of it is being used to make HbA. So there's like an excess of alpha globin chains and there's a severe deficiency of beta globin chains. So your HbF values go as high as 95 to 98%. And you also have slight elevation in your HbA2. Okay, so usually HbA2 should be less than 3%, but you can see as high as 5% of HbA2 in a beta thal majors. Now, if you have beta thal minors or your carriers, in them, the deficiency of beta globin chains is not severe enough like that of thalassemia, not that severe as that of your homozygotes or your beta thal majors. So they will have HbA production, but their HbA2 will be elevated. So like I said, HbA2 normally is less than 3%, but their HbA2 is more than 3%, so 3 to 5%. So you can differentiate these two on the basis of their clinical presentation, that beta thal majors will present with anemia, requiring blood transfusions, requiring repeated blood transfusions starting at 6 months to 2 years of age, and they will have very little HbA and very high HbF. Whereas on the other hand, here they might be asymptomatic, they might be incidentally diagnosed, and they have a good amount of HbA, but HbA2 is elevated. HbF, which was as high as 90%, is hardly elevated over here. So this is how you differentiate a beta thal major from a beta thal minor, depending on the clinical presentation as well as the HPLC report. So this is what the report for this patient might look like, and this is what the report for their parents will look like. If the parents are carriers and she is a beta thal major, then this is what the report will look like. So this is again something that can be asked, and how do you interpret an HPLC? Now, very important to remember that HPLC cannot be performed within 4 to 6 weeks of receiving blood transfusion. Okay, so let's say you've got this patient who received blood transfusion somewhere in an outside hospital and has then been referred to you with this history. So you will not be able to send an HPLC report because the child has received transfusion outside, and you can't send an HPLC. You'll get a false report if it's done within 4 to 6 weeks of receiving a blood transfusion. So in that condition, what do you do? Do you wait for 4 weeks for the patient to then come back and then send an HPLC? Is there any other way you can, confirm the diagnosis? So one way of doing it is sending a sample of both the parents to see if they are carriers. Then there's a high probability that, okay, the child is a beta thal major. And other option would be to send a genetic mutation testing. So this is again sent from the peripheral blood. It can be also sent even if the child has received transfusion in the past 4 weeks, because we're looking at the WBCs and we're not looking at the RBCs. So we're looking more at the genetic material rather than the HPLC and the hemoglobin. So genetic mutation studies can be sent even if there has been a blood transfusion recently, and it will not alter the values. And it's not even that expensive now, it's been made easily available. So that is another option. Family testing becomes very important. So you need to test the family members, also other siblings, whether or not they're symptomatic, and genetic counseling for the future pregnancies is extremely important, because you don't want to give the parents another child with beta thal major, and it is something which is preventable. Beta thal major is a big burden to the family. There's a lot of debility to the patient themselves, and if you can avoid all of this, then why not? So that's why confirmation by HPLC, if not that, then genetic mutation and family testing is very important. Now, let's say this patient turns out to be beta thal major. What are the indications of starting blood transfusion? We know that the mainstay of therapy in beta thal major is repeated, regular, chronic blood transfusions initially till the time they require, till the time they receive the long-term curative therapy. So, in anybody who's confirmed beta thalassemia, hemoglobin of less than 7 on 2 occasions, more than 2 weeks apart, is an indication for starting blood transfusions. On the other hand, if the hemoglobin is more than 7 grams per deciliter, but the child has one or more of these conditions, that there's significant symptoms because of anemia, there's growth retardation, there are complications of extramedullary hematopoiesis, like you have fractures and facial changes, or you have, sorry, this was supposed to be intramedullary. Oh, I said it wrong. Complications from extra intramedullary hematopoiesis, like you have excess expansion of your bone marrow, which can lead to facial changes or chipmunk facies, pathological fractures, or if you have extramedullary hematopoiesis causing severe organomegaly. All of these conditions, if there's presence of any one of them, even if the hemoglobin is more than 7 grams per deciliter, is an indication to start blood transfusion. So this is something that you must know, that if you have a diagnosed child with beta thalassemia, when do you start transfusions? So how often do you transfuse? We transfuse every 4 weeks at about 15 to 20 mg per deciliter. You have to give cross-matched blood. So ideally, the blood should be cross-matched for your major and minor blood groups. Minor blood groups like you have Kerr-Duffy to prevent hemolytic reactions. You need to maintain the pre-transfusion hemoglobin between 9.5 and 10.5. Ideally, you should give leuko-reduced or leuko-depleted blood because that decreases the risk of infection and other complications that you will encounter with blood transfusions. And before transfusion, there are 5 infections that you should screen for: hepatitis B, C, HIV, malaria, and syphilis. So all the blood banks are screening for all of these infections before a blood bag is handed over to the patient for transfusion. But remember that infections need to be screened for. You need to have major and minor blood group matching before transfusion. They need to be transfused every 4 weeks. You need to maintain a pre-transfusion hemoglobin of 9.5 to 10.5. The reason why this 9.5 number has come from is because when you have a pre-transfusion hemoglobin of more than 9.5, it decreases complications of iron overload, which like I have been saying is the most common complication that you will encounter with chronic blood transfusion. Even if the child is under transfused, there are other complications as to how it leads to iron overload. We'll be, discussing that some other day when I plan to take another discussion only on iron chelation in thalassemia, because that's a very important practical topic, and it's as important as knowing how to transfuse blood. Okay, so hemoglobin needs to be maintained pre-transfusionally more than 9.5, and you need to give leuko-reduced blood. What are the complications of blood transfusions? So you can have febrile non-hemolytic reactions, allergic reactions, acute hemolytic reactions if a mismatched blood is transfused, alloimmunization, TRALI, which is a transfusion-related acute lung injury where it leads to like pulmonary edema kind of picture, and infections. Okay, so that's the reason why these are the common complications that you will encounter. You will, no, I'm sorry, I shouldn't be saying that you will, that you can encounter with blood transfusions, and each one of them present differently, and the management of each one is slightly different. I'm not going into those details as to how do you manage complications of blood transfusions, but remember that it's very important to monitor your child once you've attached blood, especially once you guys become interns. Interns are the ones who very commonly start blood transfusions in the thalassemia ward. So you need to know uh, that it's extremely important to monitor your child once you started blood. So you just can't attach blood and disappear for, say an hour or so, because you never know what complication or what reaction you might have as soon as you start the blood. Okay. Other than other investigations that you need to do once you've started your child on chronic blood transfusion is to look for iron overload. So the easiest, cheapest, and most feasible method is to measure your serum ferritin, which you measure from your blood. Now, ferritin, like we know, is the storage form of iron. So all the iron that's stored in the body gets stored in the form of ferritin. So it's like an indirect way of telling you the amount of iron that's present in the body. So why do you have iron overload in thalassemia? Number one, obviously, because you're transfusing so much blood, it's transfusing so much iron. The capacity of the body to eliminate the iron is way less than how much you're overloading it. So every week, or I mean, every 4 weeks or every month, you're giving blood transfusion. So the amount of iron that's entering the body is way more than what it's able to eliminate normally. And that's the reason why you can have iron overload. Other than that, in your non-transfusion dependent thalassemias, they also have a risk of iron overload. Now, like the name suggests, they're non-transfusion dependent. So we're not giving them blood. So where is the iron coming from? Whenever you have anemia, the body tries to compensate by increasing the iron absorption from the GI tract. Okay, so the body senses that, oh, there is anemia, there's deficiency of blood. I need to do something about it. And that's the reason why it starts absorbing more and more iron from the GI tract. So, two mechanisms of iron overload in transfusion dependent definitely is your transfusion, and in non-transfusion dependent, it's because of excess iron absorption from the GI tract because of chronic anemia. So why is iron overload so toxic? Why does it lead to so many complications? Is because a lot of iron that's in the body is in the free or the labile form. Normally, when you have iron absorbed from the GI tract, it gets bound to transferrin, and that's how it circulates in the body. So any iron which is normally bound to transferrin is like inactive. So it really can't do anything. But when you have excess amount of iron and all your transferrin is saturated, like there is no more transferrin in the body to be able to transport that iron. So you have free iron or labile iron in your body, which is toxic. It releases your free radicals and your reactive oxygen species. It leads to lipid peroxidation, DNA, and organelle damage. And that's the reason why iron overload is so toxic and can lead to a variety of side effects. So iron predominantly starts getting deposited in the liver, followed by the heart, the endocrine organs, so pituitary, parathyroid, and then following which you have other complications of iron overload. So when do you start treating the patient for iron overload? We just saw that treatment is with the help of iron chelators. We look at what iron chelators are available. But when do you start the patient with iron chelation? So once the serum ferritin is more than 1000 nanogram per ml, which is usually by the time they've received about 10 to 20 blood transfusions. So that is why measuring serum ferritin regularly is very important, because the moment it hits more than 1000, you need to start them on iron chelation. So how do you treat iron overload? So you have iron chelators. How do they work? So they help in converting the water insoluble iron into water soluble iron, which then can be eliminated from the body in the bile, urine, and the feces. So it's a way of helping elimination of iron from the body. What are the common iron chelators? So you have deferasirox, which is your Desirox, which is an oral iron chelator. It's the most commonly used. It's given as an OD dosing. Okay, you do not give it BD. It's always once a day. It has to be taken on empty stomach or at least 30 minutes prior to any meal. It needs to be dissolved in a glass of water or orange juice or apple juice. Do not dissolve it in a steel glass. So this again needs to be told to the patient that when you're dissolving the tablet, so that it's in the form of a disposable tablet. So you take a glass container or a plastic container, you put about 100 or 200 ml of water or juice, put the tablet in it. It has to be dissolved well. Remember not to take a steel glass or a steel spoon, because it sticks to the side and you don't want to waste any of the Desirox. So once you have stirred it, then you're supposed to consume the entire liquid preparation that you've made. These tablets are not chewable. You're not supposed to swallow them because they are going to be ineffective. They are disposable tablets, so you have to disperse them in a liquid solution before consuming it. So that is how you take Desirox. Other iron chelators are deferoxamine and deferriprone. You need to know the names at least, and Desirox you need to know in detail that it's an oral dose, it's the most commonly used, and how do you give it. Desferoxamine is the first approved iron chelator. However, it needs to be given as a subcutaneous infusion over 10 to 12 hours a day, 5 to 7 days a week. So it's more cumbersome because you need to attach a subcutaneous infusion pump that needs to continuously infuse the drug because it's got a shorter half-life. So you need to give it for a longer duration of time. So although very effective, but it's cumbersome, it's expensive, and it's not very feasible. So, but in those patients who have severe iron overload, so let's say that uh, severe iron overload in the liver and the heart, which is almost compromising the cardiac function. In those cases, you will have to give desferoxamine, because it's very effective in being able to reduce the iron overload, but it's not the first line agent in patients who don't have severe iron overload. And the third one is deferriprone, or commonly known as Kelfer. That's the the drug name that the parents or the informant will tell you that, okay, my child is on iron chelators. He's taking Desirox and Kelfer. So when they talk about Kelfer, what they're referring to is deferriprone. So that again is an oral iron chelator which needs to be given in TDS dosing. It's given thrice a day, whereas Desirox is given OD. So many a times when your iron overload is not managed only on Desirox, you need to give a combination of Desirox and Kelfer. And if it's severe enough that it's causing compromise of your cardiac function or the severe iron overload in the liver, then you might also have to give subcutaneous infusions with desferoxamine. But I hope that this situation does not arise, that the child is having severe iron overload, that he's requiring so many iron chelators. So what does, or when does your blood transfusion requirement in thalassemia increase? So when you have massive splenomegaly, you have hypersplenism, which is fatafatsi destroying all of the blood that's being transfused. Okay, so let's say today you transfuse blood. Ideally, the child should come to you after 4 weeks for the next blood transfusion. But let's say the hemoglobin falls to 7 within 2 weeks. Then what does it indicate? When the child has an associated massive spleen, this indicates hypersplenism. So the definition of hypersplenism is when the transfusion requirement is more than 220 ml per kg per year. This is something again which can be asked. What does it indicate, or what does it tell you when the requirement of blood transfusion has increased? So basically, it points towards hypersplenism, and hypersplenism is an indication for doing a splenectomy. So you need to keep that in mind. Now, once you have a thalassemic patient who is coming to you for regular blood transfusion, is following up with you in your THAL unit or your THAL ward, how will you monitor this child? So every visit, you have to look for liver and spleen on palpation and do a pre-transfusion hemoglobin, okay, to see whether or not the previous transfusion was good enough. Like we just discussed, the pre-transfusion hemoglobin should be maintained between 9.5 and 10.5, and your post-transfusion hemoglobin should not go more than 14. Okay, although we don't measure the post-transfusion hemoglobin for all our patients, but theoretically you should maintain it such that it doesn't cross 14. Along with that, anthropometry becomes very important. Now, why is it so? So side effect of a few iron chelators leads to impaired spinal development. Okay, so obviously, number one, iron overload per se can lead to impaired growth, growth retardation, and short stature, as well as iron chelators also have the side effect of impairing the spinal growth. So that's why anthropometry becomes very important. Every time they come to you for their transfusion, which is every monthly, you should look at the anthropometry, and then you should see at regular intervals if they're faltering at their growth level, and then whether or not they have associated endocrinopathies, etc., etc. So there are a lot of things which kind of go together, that can impair the growth in these patients. So they are chronically anemic. They have an anemia of chronic disease, so there's chronic ongoing inflammation and ongoing process. Along with that, especially if they're under transfused, or if they have iron overload or complications of iron chelators, all of this can contribute to growth retardation. So that is another thing that should be kept in mind. Serum ferritin at regular intervals to measure iron overload, and if not started on iron chelators, then the moment the serum ferritin exceeds 1000 ng per ml, you need to start them on chelation. Hepatitis B, C, and HIV, because you're transfusing blood, they're at risk of transfusion related infections. Renal and liver function test, again, iron chelators like your Deserox are known to be renal and uh, hepatotoxic. So doing RFTs and LFTs at regular intervals will tell you if or not they're having any of those side effects. Eye and hearing test. So you should do a baseline ophthalmic and audiological evaluation before you start chelators, because again, a few chelators have side effects impairing the vision in terms of retinal toxicity. So your desferoxamine, the subcutaneous infusion wala drug, causes audiological impairment, causes retinal toxicity. So regular, at least yearly, formal evaluations of your eye and hearing should be done. Endocrine evaluation, so blood glucose, TFTs, and pituitary functions starting from say adolescence, and needs to be monitored regularly. And last but not the least, iron overload in the liver and the heart on MRI. Okay, so I will be taking another session only on iron overload and iron chelation and thalassemia, because it is extremely important to understand. So I'll be discussing all of that in detail there, but just important to know that there's something called as T2 star MRI. T2 star MRI, which is used for evaluation of iron overload in the body. So because the liver and the heart are, organs that are affected first when it comes to iron overload, we always, like, after a certain age, look for iron overload with the help of T2 star MRI, because serum ferritin is not that I would say, efficient or not that reliable only when it comes to iron overload. So we need to look for which organs are affected, how bad are they affected, and accordingly you will have to titrate your iron chelation. Lastly, yes, we do have long-term cures for beta thalassemia also. So bone marrow transplant, gene therapy, and luspatercept, which is a recently approved drug, although not in pediatrics, but definitely in adults. So these are the few other treatment options available, uh, which can be used for long-term cure of beta thalassemia. Okay, so although the mainstay, like we've been discussing, especially in our country, is still repeated blood transfusions, and along with that, to be sure that you're chelating the patient well. But a lot of research is being going on as to, giving these patients a long-term cure and once and for all cure for the beta thalassemia. So we have transplant, gene therapy, and newer drugs like luspatercept. Even thalidomide is being tested. So this is interesting to know, good to know, and hopefully one day we will have like a cure for beta thalassemia, all patients. Okay, so let's just keep our fingers crossed. So that concludes our discussion on approach to anemia with hepatosplenomegaly. So we saw the approach, we saw the history, examination, and we've come to a diagnosis. Again, I wanted to take the discussion more towards thalassemia because that's one of the most common causes of anemia with hepatosplenomegaly, and the most common hemolytic anemia, and a high likelihood for you having a patient or having a case of thalassemia in your exams. Okay, someone's asking mechanism of action of luspatercept. Okay, so luspatercept basically acts on the TGF beta pathway. It helps in the maturation of your RBCs or your erythroid cell lineage, and there's a particular pathway that it inhibits, the SMAD2 and 4. I'm not going into those details, but if you really have to remember, it basically helps in maturation of your erythroid cell series and inhibits the TGF pathway. That's, I think, should be enough to know. Anyways, I am taking another session on iron chelation for thalassemia and newer therapies, where I will be discussing more in detail about bone marrow transplant, gene therapy, luspatercept, and the other drugs that are under trial for thalassemia. So hopefully that will answer your question and you'll get more insights into that. I hope the approach has been easy to understand. Now, when you have anemia with hepatosplenomegaly, you can also have other differentials like um, you can have somebody who's having malignancy, or it could be a storage disorder like, say, Gaucher's or Niemann-Pick, or it could be less likely, but yes, you can also have liver failure with portal hypertension. So any case of anemia with hepatosplenomegaly needs to be approached the way we've just discussed it, but your differentials and your diagnosis can be different. So it need not always be beta thalassemia, although hemolytic anemias is, the commonest that we encounter. But remember that your questions in your history and your examination should give you a clue as to what you think you're eventually dealing with. And it can be different from what we've discussed today. But approach, like I said, is very important, and we've discussed that in detail. So I hope that's answered your questions. I hope this session was helpful. And if you have any questions, have any doubts, you can definitely put it up on the WhatsApp group. And thank you once again for attending the session. And I hope this was helpful once again. And yeah, have a nice day. Thank you, guys.